Thanks for joining us, everyone. Reminder for our case presentations, please avoid using personal health information. Next slide. And here are the usual reminders about any assistance that's needed. Next slide. And here's our summary slide about cardio. Next slide, please. And we can get started with today's presentation, which I will be giving. We have two really interesting cases. I had a chance to look them over yesterday by Megan and Melissa that I will discuss along with Chris. Next slide. Here are disclosure statements. I don't believe there's any new disclosures from any of our participants. Next slide. And we're going to talk about empowerment. So I think there's many ways to think about empowerment. And I got interested in this issue quite some time ago, probably about 12, 13 years ago. And it came to light because I was the PI of a project in Chicago. It was carried out in a FQHC that had multiple sites across the city. And the goal was to improve diagnosis and management of hypertension in children. And we developed a number of interventions around it. We actually had an echo curriculum. You can imagine doing 12 hours on pediatric hypertension. We actually had an abbreviated version that was 3 hours long. We had clinical decision support tools. We had an information session for physicians. We trained nurses and medical assistants on corrective measurement and counseling. And we actually provided that similar type of counseling to patients as well. But of all the interventions we developed, the most effective was a sign in a waiting room, which cost about 50 cents, that said, ask your doctor about your child's blood pressure. That was it. Just in bold letters. And what happened, of course, is that most people ignored the sign. Some people would go in for their child's child check or whatever it happens to be and say, I saw that sign out there. Can you tell me about my son's blood pressure? Now, given all the impetus that we had, which of course was marginally successful, imagine you're a physician with this mother who has her 7 or 8-year-old son there, and she's asking you, tell me about my son's blood pressure. Well, you've got to go through your electronic health record and figure out what percentile he's at. You've got to give her some accurate information. And suddenly, boy, enrollment in the echo curriculum started to go up. People started to pay more attention to it. What happened, I realized, was that all the measures that we think are effective, passively giving information to patients, it's often become almost this default sort of thing. Well, my patients don't have access to the web, or they don't have access to good information, or perhaps they have low health literacy, and therefore I can't help them. I wish I could. But the most important thing is to encourage a patient themselves to feel empowered. Next slide, please, Rick. So I want you to be able to define patient empowerment, and the definition I'm going to provide is the official one, which I don't especially like, but we're going to go with it. Describe empowering patients to seek high-quality care for the prevention of cardiovascular disease. So in other words, strategies to do it. Describe an approach to patient empowerment within a busy primary care practice. Next slide. Now, this does not have to be delivered by physicians, nurses, pharmacists. It can be anyone who is in that healthcare setting. So first of all, let's talk about why we have gaps in care. So patients with diabetes and established cardiovascular disease, that's a pretty select, high-risk population. About 58% have controlled blood pressure. That's not great, right? Why is it? Well, do we not have guidelines for how to manage blood pressure? Of course we do. Are there not quality measures and standards and associated provider incentives? There certainly are. I'm a department chair here at University Hospitals and at Case. I can tell you that there are standards and incentives tied to them, but that 58% doesn't move a whole lot. Is there a lack of innovative models of care? The patient-centered medical home, complex primary care, the chronic care model, which I'll talk about briefly. No, those have been around. Some of them have been around for 30 plus years. So here's a quote. I think it's from Health Affairs. There's no lack of tools, programs, and models of care, many of which are linked to financial incentives for physicians for their effective use, available to improve quality, and the lack of such resources cannot explain widespread quality problems in the United States. Okay, next slide. So what is the explanation for why not all of your patients, and we've had some really interesting case questions. Why are they not achieving their goals, whether it's for diabetes, whether it's for hypertension? Well, there are some things to consider. One is the phenomenon of clinical inertia. And I can tell you, this is a pretty real one that I experienced. I'm trying to scroll through and see who's a primary care physician. Nathaniel is. Okay, so let's say Nathaniel and I are in practice together, and I see one of his patients. Let's say it's an older gentleman, and his blood pressure is out of control. And Nathaniel has him on chlorthalidone and amlodipine. And I look back, and there's 3 or 4 visits he's been seeing other people. He hasn't seen Nathaniel for about 6 months. And I'm saying, but he's coming to me because he has an ankle sprain. And I say to myself, really, I don't want to get into a big discussion with him about intensifying his treatment. I'll let Dr. Harris deal with it. And then Dr. Harris sees him a regular checkup, and he says, well, it's interesting. You saw Dr. Rao last month. He probably had something in mind for your blood pressure. I'm going to wait a little while and have you see him again. And he comes back to me, and we do the same thing, and nobody actually takes action. So it's clinical inertia, because I think it's brought on by the fact that a lot of our patients have other needs, and a lot of cardiovascular risks are asymptomatic. But you can only define clinical inertia if 3 conditions are met. There has to be an explicit guideline for it, okay? So in the new diagnostic center we're dealing with the problem of unintentional weight loss in the elderly, and nobody knows what to do about it. So if I have clinical inertia, in other words, if I don't do something about it, maybe it's not because I don't want to do something, I'm not sure what to do. The physician or provider has to believe in the guideline and that it applies to their patient, and they have to have the resources to apply that. If I have 27 or 30 patients booked per day, I'm not going to get into a big discussion with my one patient that has blood pressure that is in the stage 2 range and could use intensification, and especially if he's not there for that reason, right? So time is a resource that I need. Only under those conditions can I say that clinical inertia is present, okay? Now, the other explanation for why we don't meet goals is our patient factors. Now, this is one that we face a lot, and Jim and I face it a lot in terms of obesity management as well. Poor engagement with care, limited interest in self-management, including lifestyle modification. We have a number of people from the nutritionist world, and I can remember, working with a dietitian a long time ago in Pittsburgh, and she told me that one of the worst consults they can have is a patient who is in the inpatient setting who is about to get discharged home because they had an MI or something after several days. And her job is to provide them with dietary advice. And she said, they're really not engaged and they don't want to hear it. It's not a great time. Passively delivering information in one occasion is not going to have any impact at all. So this is a significant factor. And there are many ways to overcome it, which we'll talk about. And of course, there are system factors which explain why we can't control cardiovascular risks, time and productivity pressures. Those are not new. But what is also a factor is primary care structure is not designed for management of chronic illnesses such as hypertension and diabetes care. It's designed for episodic care. The reason is, even if your appointment is just a little bit longer, right? Even if the patient is sitting there and watching a video on how to cut back on their salt, it can have an impact on them, but we don't have time to often do that because we've got to go on to the next patient. Next slide. So the solutions, to this problem of improved management of chronic disease, cardiovascular risks included, have been around for a long time. This is the most well-known of them. It's the chronic care model. Okay, the chronic care model integrates many different aspects of care, from community resources in the health system, how we design our delivery system, self-management support, which empowerment is quite linked to, decision support, which of course within the era of EHRs is very important, clinical information systems. So Epic has a feature called My Panel. I can look and see how many of my patients have a hemoglobin A1C of 9.0 or higher, for example, and target them for follow-up, et cetera. What that is supposed to do is to create productive interactions, an informed, activated patient, which we'll talk about, in combination with a prepared proactive practice team for improved outcomes. This is all wonderful in principle, but more than 30 years after this was developed, it has been implemented successfully in some places, but mostly just in bits and pieces. And the actual impact on outcomes is questionable. So I think we need a completely different approach to it. Next slide. So look at some of the other things. One is shared decision-making. And I highlight these concepts because I think they're related to empowerment. Shared decision-making is an approach where clinicians and patients share the best available evidence when faced with the task of making decisions, and where patients are supported to consider options to achieve informed preferences. I use this almost all the time in our weight management, in our Fit or Me program. After a few months, I'll say, you're doing pretty well. You've lost about 10 pounds. And we can have a discussion now about medications, because you've asked me about that before. How do you feel about it now? Let me give you some of the options that are available. And, one of the big considerations is insurance coverage and cost. He goes, well, how do those options strike you? What direction would you like to head it? You'll notice I don't make the decision usually. I mean, sometimes I'll make the decision not to give them medication, but I usually don't make the decision. It's the patient deciding with me based on the information that I've provided. And that's a shared decision-making process. A related concept is activation. A patient's willingness and ability to take independent action to manage their health and overall care. There's strong evidence that more activated patients have better outcomes. More activated patients with diabetes are likely to perform foot checks, eye exams, and exercise regularly compared to less activated patients. We've probably all had the experience of a patient coming in with, let's say it's with their spouse or by themselves, and they pull out a little piece of note paper and they have their blood pressure measurements recorded on there, okay, in pen. And they say, look, doctor, this is what I'm getting at home since you started the new medication. Boy, I can tell you that patient is going to be at lower risk of having a cardiovascular event, right, than other patients are, because they are activated. They are taking responsibility for their illness in that sense. Next slide. So the relatively new concept of patient empowerment, at least relatively new to us here in North America, it is defined as a means to promote autonomous self-regulation so that the individual's potential for health and wellness is maximized. I don't especially like it. I imagine trying to explain this to a patient. I'm promoting autonomous self-regulation. But the potential for health and wellness is maximized. I mean, that's true, of course, of activating a patient. That's true of our delivery system design, et cetera. Next slide. So this is the European Charter of Patient Empowerment from the EU, and all its member states have adopted this. I like it, and I'm going to talk about some of these statements in a little bit more detail. I am more than my health condition, of course, makes sense, right? I am empowered to the extent I wish to be. Some patients do not wish to be empowered. Now, I'm looking at some of the physicians here, whether it's in the APPs, Nathaniel and Kathleen, I think I saw on as well. We've had the experience when you start to present options to a patient, and they said, what do you think about it? And then I've heard this many times. Well, I don't know. You're the doctor. Shouldn't you decide? I've heard that lots of times. That doesn't necessarily mean that they don't want to be empowered, but they don't want to be empowered to the extent that you perhaps wish them to be, or perhaps you expect them to be. That's completely normal. I'm an equal partner in all decisions related to my health. I have the information I need in an easily understandable format. Printing out things and giving them to a patient is not an easily understandable format, especially if they have low health literacy, okay? And for those of you who have EPIC, the AVS, the after visit summary, can be customized to what's there. Sometimes just a few words in bold letters is what's needed. My health professionals and our health system actively promote health literacy for all. I have the ongoing support to manage my own care. My experience is a vital measure of healthcare quality. Really, really, really important aspect of empowerment. We have so many quality measures, okay? Our Chief Transformation Officer, Peter Pronovost, in my system, was charged by Medicare to consolidate the quality measures because there are so many across the government. I'm part of the National Quality Forum, and the Quality Collaborative decides upon primary care measures. But then And we report to CMS, but there's other organizations. There's a National Committee for Quality Assurance. There's private organizations. Every health system has their own quality measure. How do we consolidate all of these things? And what do they look like? Well, hemoglobin A1C under 7.0, blood pressure control, smoking cessation, was it delivered? Yes or no? Smoking cessation counseling, yes or no? Was it delivered? Did children get their HPV vaccine? Did adults get their influenza vaccine? Very, very objective, measurable sorts of things. But did anyone ask the patient, did you have a good experience? Okay, that's an important thing. You know, I saw Dr. Dungan, and my experience in her looking after my diabetes was excellent. Okay, let's say a patient says that and hemoglobin A1C is still 11, and Kathleen's been trying for months, and she, you know, I've referred the patient to her. Nobody seems to be able to move the patient. It still counts because she, you know, he or she is having a good experience. I can participate in evaluating, co-designing healthcare services so they work better for everyone. We do this to some extent, mostly through research. There are lots of stakeholder panels that help to design the experience. Through patient organizations, my voice becomes part of a bigger united voice. So I'm one of the leaders of the Society to Improve Diagnosis in Medicine. I tell you, the patient organization part of that organization is just as big and just as influential as the scientific leadership. And equity and empowerment go hand in hand. I want a fair deal for all patients. So our goal in our department and our network of practices is to give the patients who come to our Bolwell Family Health Center on main campus, which serves the economically challenged areas around Cleveland, the same experience as they would get in an affluent suburb, right? So that's part of the fair deal. And the fair deal is something I'll talk about in a moment. Next slide. So what is empowerment? How does it affect minorities? How does it affect those who've traditionally not been able to take advantage of the highest quality of healthcare? And I'm going to draw your attention to this slide because this is not about empowerment. Empowerment is not necessarily how you perceive the quality of care to be. And it is encouraging, this news. So Black adults generally give high marks for quality of care. And here's the thing, not a whole lot of variation by income, okay? And 40% of Black adults say they've had to speak up to get proper medical care. So this is, you know, and you look at all adults, there's not a huge difference here, okay? And some of these questions are really interesting. Pew is, of course, a very reputable center. So if you look at felt you receive lower quality care, it's slightly higher than all adults, but not gigantic differences here. But what it points out to me is it's not just minority patients who may not feel empowered, it's all of our patients that need to be empowered, okay? So, and that I think speaks to the diversity of our cardio group here. We come from many different regions of Ohio. But I will tell you a few things. It doesn't seem to be big sex differences in this. Racial differences, if they are there, they are slight. I can tell you that given that we're dealing with cardiovascular risk, generally speaking, older patients feel less empowered. And I think it's our own natural bias. Somebody comes in at age 80 or 85, maybe Nathaniel and I are saying, I don't know, you know, I could increase his blood pressure medicine, but gosh, you know, maybe not. He's not going to get it. You know, he can't see very well. He doesn't hear me very well. And people tend to become very passive as they get older. That's sad. We have to change that. Next slide. Okay, so together with some of our team, this is a proposal we submitted for a grant to a private company. And it's a complicated story. I cannot accept research money from private companies anymore because of my role with the federal government. But this was the idea, and they were actually excited about this. And lots of people have tried to develop interventions to improve the quality of diabetes care. So many of them, right? You can imagine quality measures, incentives, devices, videos, patient education strategies, clinical decision support, all kinds of things. But how about a simple checklist which prompts the patient to seek better care for diabetes. The underlying principle is that every patient, no matter what their age, sex, gender, ethnicity, race, whatever, has the right to the highest quality care to which they are entitled. I mean, of course, insurance and other limitations aside, right? Everybody should get the highest quality care. So our strategy initially was to ask our patients to complete this checklist just prior to their appointment. Has your doctor discussed improving control of your diabetes? I certainly hope so. Has your doctor talked to you about changing or adding medicines? Medicines to prevent further heart disease, your blood pressure, your cholesterol, exercise, smoking cessation, urine. Have you seen an eye doctor? Has your doctor offered a flu shot? Now, I'm going to stop there for a second. So this is the basics, right? And the way it's framed to patients is you are entitled to the highest quality of care. These elements constitute the highest quality of care. Complete this checklist, bring it in to your encounter, into your exam room with your physician, and let's talk about it. Now, of course, there was a concern that this might be demoralizing to physicians, but the evidence has shown from other studies of this type that it actually makes the encounters much more enjoyable, right? And actually makes things a little easier for a physician to say, you're right. I ought to check your cholesterol. Let me check. Now, the final two questions were added by Kurt Stange, one of my colleagues here at CASE, whom many of you know. And Kurt and his colleague have developed a very innovative measure to measure the quality of primary care. So most quality measures are very disease focused, but his primary care measure is a global measure of quality. And we presented that to the National Quality Forum, and it has been adopted as a national quality measure. So these two questions are adapted from that. Does your doctor know who the most important people in your life are? Why is that important? Well, it really tells you, does your doctor really know you, right? You remember the first line in empowerment is, I am more than my disease. I write stuff down. I say, if someone said, if my patients come in and say, oh, we went to Las Vegas 2 weeks, we're going to Las Vegas 2 weeks ago, and they come back a couple months later, and I will ask the lady, how was Las Vegas? And they were like, wow, he remembered we went. Of course, I didn't remember. I wrote it down in my note, but it's not the point. I do know something about them. So you are more than your disease. In caring for you, does your doctor consider all the factors that affect your health? And I really like this statement as well. And you can look at Rebecca Etz and Kurt's measure in more detail. There are many things that consider your health beyond the medications that you take, right? So think about how much our older patients have suffered over the last 2 to 3 years through this pandemic era. There's still many who are afraid to go out. They have become socially isolated. There have been fewer visits from children and grandchildren. These are people who are not generally working or in school or have other means. They're, technologically, and Kelsey knows this very well, are not as savvy as others to do Skype and other meetings. Yeah, maybe that's going to have a big impact on their health, right? We've seen some troubling statistics in that regard. So this is our empowerment checklist. This is one strategy. Next slide, please. So a few other questions. Now, you may not be able to do an empowerment checklist for diabetes every single time. And as I said, we haven't had a chance to study it formally. But here are some ways to phrase empowerment within the context of an encounter in the right way. So we often say, and I do this as well at the end of an encounter, do you have any questions? Any questions? What do you think the default response is, especially from your 80-year-old? No, I think I'm okay. And is that really because they have no questions, or they're not sure what the questions are that they need to ask? Maybe they feel that you're busy and this is just a way for you to wrap things up. Maybe you haven't given them time to think about what questions they have. So how about switching around and saying, instead of, do you have any questions? What questions do you have about your visit today? Make good eye contact and say, and wait for them to respond. Okay. And I guarantee a lot of those questions are going to be things that you already covered. But if they don't understand, remember, empowerment, if they don't believe they got a flu shot, they didn't get a flu shot. You have to address that, right? You have to show them that they did. right? So ask them, what questions do you have? Don't ask them, do you have any questions? Number two, what do you believe you need to better manage your diabetes, hypertension, whatever it is? That is the way to ask it. Not, here's what you need to do to better manage your diabetes. Here's what I need you to do. I need you to take your metformin twice a day instead of missing 3 out of 5 days. No. Because when you ask, what do you believe you need? They will tell you, I need a reminder on my smartphone and I can't work this thing. And my daughter is away right now and I can't see the numbers very well. I can't set an alarm so I can remember to take my metformin. Boy, that's a different conversation, right? Number three, how can I help you achieve your goals? Versus you need to be more consistent in taking your medication. Most people want to stay healthy. They want their disease under control. What can I do to help you? Is very different than saying, here's what you need to do to achieve your goals. Okay, next slide. Okay, thank you very much. And I'll take some questions before we move on to our cases, a minute or two.
This is Nate Harris. I had a question regarding when, say, for example, patients' goals may kind of be counter or opposed to active guidelines. So say, for example, in management of hypertension in the elderly, you know, they desire to avoid polypharmacy or taking multiple medications, et cetera. And so granted, you know, usually the discussion, especially here lately, I've had is like, well, you know, you'd benefit over the long run of having, you know, a lower blood pressure, but, you know, you're at higher risk of falls. And so it's kind of hard to have shared decision making in that group, you know, because it's like, well, less sometimes can be more. So, you know, avoiding the medicines, et cetera. And granted, in people who, you know, don't have, you know, a history of coronary artery disease or diabetes, et cetera, they may possibly have more leeway in the sense that given that they don't have those risk factors, they could possibly do just as fine, you know, with a slightly higher blood pressure. And so I was just kind of wondering, you know, how do you walk that?
That's a great point, Nate. I think that, remember, the patient is our focus here, okay? So yes, there are quality measures for blood pressure control over a certain age, et cetera. Let me give you a couple of points. So I have a patient who is suffering from unintentional weight loss. I think she's 86, very tiny African-American woman. She wasn't very big to begin with. She's lost 14 pounds. And I said, I want to send you for a colonoscopy and do a CT scan because I'm concerned there might be a malignancy here. And it's something I'm worried about. And every time I see you, you seem to lose more weight. And she says, I have a normal appetite. I don't know what's going on. And I've had detailed discussions with her. Her response is always the same. No, thank you. No, thank you. I don't want to go through all of that. I'm comfortable. I know what the outcome is going to be. I know it's going to come relatively soon. I've lived a good life. That's fine. I have to respect that. Okay. Ezekiel Emanuel, who is Ram Emanuel's brother, is a physician as well. I think he sent something out recently that said once he turns 75, he's refusing chemo. If he has cancer, he's refusing chemotherapy, colonoscopy. I don't know why he said flu shot. He's not getting a flu shot. And he said, look, you know, because a lot of those things are not things that he wants. So I think we have to respect it. So your patient who has, you know, hypertension, you're saying, well, you know, this might make you at higher risk for falls. What do you think? That's one way of phrasing it. And I often will say, if you were my mother or if I was in your position, this is what I would do. Okay. And I would be sincere about that. But I'm not you, and you have maybe different values, and see where that discussion goes. But I don't tend to overtreat people that don't really want it. That actually breeds a lot of resentment as well. Okay. Any additional questions? We'll take maybe one more. Austin? I can't hear you, Austin.
Do you think they'll ever actually consolidate all these quality measures?
Oh, the effort's been going on since 2020. I think we have to. You know, it's it's a major effort, and some of them are, you know, I think that quality measures have to be aligned not just with the disease, but with societal values as well. And there's a big focus on health equity too. So there's got to, it's not just consolidation. We have to rethink what it means to be healthy. So I think, but it's a gigantic project. And I'm glad that I'm glad Peter's in charge of it.
Dr. Rao, I
Yeah.
have a quick question. Just as a new, I'm still kind of learning all of this as a new provider, and I guess one of the biggest frustrations I kind of run into is this clinical inertia where a patient will see multiple providers, and then I feel kind of stuck, for like a better word, taking care of all of these issues. How or what advice would you give to newer providers when dealing with this clinical inertia
Yeah.
and how to balance that?
Yeah, great question. So how do you overcome clinical inertia if that is really the problem? Now, I mentioned that sometimes it's overcalled, right? You know, it's like, no, I don't think I want to treat my patients with the new SGLT2 inhibitors because they're too expensive. It's not that I have clinical inertia. So we have to clarify that. Blood pressure is the ideal example because many patients have uncontrolled blood pressure that goes on and on and on, and nobody does anything about it. Why are they not doing anything? First of all, they feel they're too busy. It'll be somebody else's problem. Okay. So I think the best way to do that is actually an empowerment strategy. So I told you about the pediatric one. Give them a piece of paper and then said, hey, ask your doctor about your child's blood, about your blood pressure and whether it's under control or not, and what you can do to improve it. Okay. That actually puts the provider in a position where they must do something about it. Otherwise, you know, imagine, no, don't worry about it is not the good right response under those circumstances. It seems to be the only way, Amber. We can put clinical decision systems in, alerts in the EMR. It has a marginal impact at best. The patient has to be the focus of how we improve quality of care. All right. I think we need to go back to Claire for a couple of minutes for some reminders.
Sure. So just a reminder that the cardio webinar is next Wednesday. If you're interested in joining, you can register at cardio.org. We would love to see all of you guys there. Next slide, please, Rick. A couple of reminders. So the post-clinic survey should have been sent to you about 15 minutes ago. Please fill that out just to give us feedback on today's talk. And then we are still short on cases. So please email me if you're interested in either submitting an additional case, or if you have not submitted your original ones yet. We do need 5 more to fill out the slots. So.
Okay, thanks for that reminder, Claire. If you have an interesting case, you can also email me just in advance to just let me know a little bit about it, and we can help you kind of flesh out some details as well. Everybody have a wonderful week, and we'll see you next week.